First of all, I'd like to welcome you all today. My name is Marty Mascari. I am a contractor with the North Central Texas Area Agency on Aging, and I need to be very careful to do the right job today since my boss is one of the presenters today. I work under Doni Green at the Area Agency on Aging, and so we're blessed to have her today as a speaker. We are doing this under a caregiver grant under Health and Human Services, HHSC, and we have gotten funding to do several more webinars than we usually do, and we're not able to do our in-person events. So hopefully after this, you'll look out for several other webinars we have coming up. So to get started, the first thing I'm going to do is ask Jamie Cobb. Jamie's with the James L. West Center in Fort Worth to talk about the CEUs for today. If Holly, you can advance to the next slide. Jamie?
Thank you, Marty. Yeah, and thank you all for—
I cannot hear you. Are you muted?
I can hear you.
Holly can hear me. Can anybody
Yes.
else hear me? No,
Yes.
Okay.
I can hear you.
Okay, perfect. Well, we thank you all for being here. And we are so happy to be able to offer continuing education credits for social workers and licensed professional counselors here in the state of Texas. And if you need a certificate, just a generic certificate of attendance, we can do that as well. You will receive a follow-up email after the program is over with a link to an evaluation. The evaluation will go through SurveyMonkey, and once you complete that evaluation for the program, then you will receive your continuing education certificate within about 3 to 5 business days, and you'll receive it through the email address you provide in the survey email. You must be on the entire webinar series. We'll ask you what time you signed in and signed out, but we'll be able to verify that through the Zoom registration. So we ask that you stay on for the whole series, or the whole program, excuse me. And the link for the survey will only be active until the end of February. So the last day in February, the 28th, you'll have that amount of time to go and complete that evaluation to obtain your 1 hour free continuing education credits. Again, you will receive a follow-up email with all that information and the link and everything like that from Marty after today's program. We thank you all for being here.
Very good. Thank you, Jamie. Thank you for doing that. I appreciate it greatly. So our first speaker is Hollie Glover. Hollie works with Jamie at the James L. West Center. She's the Director of Education and Family Support Services, and she's going to talk to us about depression versus dementia. Hollie, I'm turning it over to you.
All right, thanks. Okay, so like they said, you're going to get a copy of these slides if you haven't already. If you don't get it, please check your spam, and you can also get back with Marty. He can send them to you. This slide has a little bit of information about me. I have presented on here before. We always love being part of this, and this is such a great topic. We were asked to put together a program on this. We get a lot of questions. So I work here at the West Center with Jamie. Like we were saying, I'm the Director of Education. I'm a licensed professional counselor. So I run our support groups, and one of the things that I have the privilege of getting to do is to help take care of the families, because we know that with dementia, the family is called the hidden patient. And so I get to walk on this journey with the families and hold their hand through this. So let's get started. And again, we are not going to unmute everybody, but we will have Q&A. You can put stuff in chat. Jamie, Marty, Doni can interrupt me at any time. We can stop, but at the end, we will do questions and answers. So here's our educational objectives. Some of the things we're going to talk about is defining depression and dementia. We want to make sure that we understand exactly what they are, because even those who work in the field many times do not understand how wide and deep dementia and depression, they both have a lot of aspects to them. And then we're going to go through the symptoms of each. We're going to talk about the different types of each, and then we're going to talk about treatment options, and then we'll have time that we're going to give you some resources as well. So this is a really simple definition of depression. And normally when we think of depression, whenever I'm talking about it and I say, when you think of depression symptoms, what's the first thing that comes to mind? And I would love if you would type that in chat. If you hear the word depressed, somebody is depressed, what is the very first thing that you think of? Let me see a few things that comes up here. Sad, 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 suicide, sad, angry, sad, extreme sadness, dark. You notice the word we're feeling, we're having a lot of here, sad, isolated, yes, everything looking gray, low energy, exactly. No hope. But that word sad came up over and over and over again. There's over 20 common symptoms to depression. You can actually get diagnosed with different types of depression and not be sad. And anybody who has suffered with any type of depression probably understands exactly what I'm talking about. You can be someone who on the outside appears to have it all together, and you may truly not feel sad, but you've got a lot of other signs and symptoms. And that's why so many times people will say, I'm not depressed, I'm not sad. It's not just about being sad. So let's look at what the definitions are. Common and serious, and notice this says medical illness that negatively affects how you feel, the way you think, and how you act. It is a feeling, and I saw some of these words pop up: despondency, hopelessness, dejection. It can happen at any age, but often it is in adults. So let's look at those symptoms. There's a lot of stuff on this page. Now, persistent sadness or an empty mood is right there at the top, because that's typically what we see. But you'll notice on here a whole lot of things that it's not sad. So I'm going to give you just a second to look over that list. Depression affects different people in different ways. We're all individuals. So what depression looks like in one person is not going to be what it looks like in another. We've just been through a year of a pandemic. We have got some of the highest numbers of people getting diagnosed with depression and anxiety that we've ever had. Our world was turned upside down. Change is difficult for us anyway. Any type of change is difficult. We kind of get in our habit, this is what's going, I don't want a new normal. So if you're seeing yourself in some of these, irritability, feelings of worthlessness, not wanting to do anything. I saw apathy came up on there several times. Restless, but I don't know why. I can't make a decision. I'm having some aches and pains. I've developed IBS, irritable bowel syndrome, because our brain is dumping cortisol. We're staying in that fight, flight, freeze all the time. So let's look at depression symptoms in older adults. So this would be in people over the age of 65. So depression is not a normal part of growing older, just like dementia is not a normal part of growing older. We'll talk more. We're going to do depression first and then dementia. We'll kind of see the overlap. This isn't something that just happens because we're getting older, and it should most definitely never be taken lightly. I saw several people wrote the word suicide on there. I'm doing a program later in the week for Leading Age Oklahoma, and I'm talking a lot about suicide and the fact that 40% of all suicides in 2020 were healthcare workers. 40%. That means that most of us on this call right now either know somebody, we were affected directly. 40% of all suicides were healthcare workers last year. And we're going to talk about why that was also. So in older adults, let's look at how this can present. Depression will often go undiagnosed and untreated because lots of times they're reluctant to ask for help. And they may look a little different and be a little less obvious. because depression can have memory difficulties. Somebody who is having a major depressive disorder or a major depressive episode can have memory loss. The word memory loss does not mean dementia. That's why we always tell people, if somebody is starting to first have symptoms of what you think is dementia, get to the primary care physician first, because we want to run tests, we want to do blood tests, we want to do a complete history with them to rule out something that is treatable like depression. So in somebody who is older, if you're seeing some of these things, personality changes, maybe some physical aches and pains that they weren't having before, fatigue, they're just losing interest in everything. They want to stay home all the time. And then if they have suicidal thinking or suicidal thoughts, and they are a man over the age of 65, that is the group of people who don't attempt, they commit suicide more than anybody else. That is our highest. And normally, again, when you ask folks about suicide, they'll say teenagers, college students. It's staggering. It's men over the age of 65. Now, attempts are women, middle-aged women, are who attempts most often. But who succeeds are men over the age of 75. So there are different types of depression, just like there's different types of dementia. And again, most people don't realize this. We just say depression, and depression is also an umbrella term, just like dementia is an umbrella term. And there are many different types of depression. I am just going to talk briefly about the 5 of the most common that we see. I'm not going to go into bipolar. That's a whole different program on its own. Of course, that has depression with it, but we're going to talk about these 5 that we see. So there is a chronic depressive disorder or a persistent depressive disorder, dysthymia. And that is a depression that lasts for a minimum of 2 years. And they have major depression. It comes in bouts with periods of less severe symptoms, but it's always there. It is not that it's coming and going, it's always there, but it gets worse at times. Then here's one that you may have heard about, postpartum depression. You may have had somebody who had, you may have been someone who had postpartum depression. And that is a depression, and this is something that is not the baby blues, because we hear people, oh, that's just the baby blues. Postpartum depression is much more than baby blues. It is feelings that are so extreme and they're so exhausted that they can't even take care of themselves or their newborn, or they don't want to. They just can't do it. It's a real thing. Then there's one that is very, very common right now. And if I had my screen where you could see what's sitting right here beside me, you would see something that I use to help with seasonal affective disorder, SAD. This is depression that we have during the fall and winter months when there's less natural sunlight. It is a very, very real thing. Usually it has social withdrawal, increased sleep, weight gain, and they'll say, oh, it's just because it's fall and winter, I'll get better in the spring. And you do get better in the spring, and then in the fall it comes on again. Actually make a light. The one that I have is called Happy Light, and it mimics sunlight, and it's something that you can have in your office. Our social worker here used to be in Alaska, and she said that in Alaska they actually put these lights in the walls so that they had them in their office. So this is something that is, again, it is very, very real. And then there's major depressive disorder. This is clinical depression. And this is symptoms that you have most of the day for 2 weeks that interfere with the ability to work, sleep, study. It interferes with every aspect of your life. You can have at least 1 episode during a lifetime, or you can have multiple episodes during a lifetime. A major depressive disorder. So you noticed up there with the chronic depressive disorder, that's 2 years. But major depressive disorder, 2 weeks. Now, here's the one that we see most often, and all of us will go in and out of this, whether we call it this or not, that we will go in and out of situational depression because of life. That's feelings of being sad or being very low because of a situation. We lost a job. We broke up with somebody. We got a divorce. Somebody died. It's grief. Grief comes in waves, but usually with grief, our self-esteem is still maintained. Now, you can have grief and be depressed at the same time. They can coexist. But typically, this situational depression is something that even though we're very, very sad, again, that self-esteem remains intact. So whenever I'm talking with caregivers of those with dementia, and they will talk about being depressed, and absolutely they can have depression. They can definitely have persistent depressive disorder because it goes on for so long. But sometimes they have situational depression because of an event or an incident, because of something that has happened. So let's look at the risk factors for depression. Depression and anxiety, like I said earlier, the most common mood disorders in the United States. Only 1/3 of those who suffer ever get treatment. Healthcare professionals are at a very, very high risk for depression and suicide. One of the reasons that healthcare workers go untreated is because most of us have a wall full of certificates and license and diplomas that say that we know what we're doing. The state of Texas has issued me a license that says that I am a licensed professional counselor, so I should be able to get on top of this. It says that I'm a nurse. It says that I'm a social worker. It says that I'm a physician. And how do I then say that I'm having problems with depression and anxiety? We're afraid. We've got that license. We've got that certificate. Now in women, depression tends to rear its head, and we will have that sad and lots of feelings of worthlessness, hopeless, and women also have a lot of guilt whenever they are depressed. In men, you will see more irritable, angry, being very tired. Now, if you look there under genetics, family history of depression about 40% of the time. And I thought it was interesting to see that in identical twins, about 70% of the time, if one has it, the other one will. There's the biological. 1/3 of women will have a major depressive episode at one point in their life. Now that's those that report it. So my guess is that's a very low number. And part of the difference is that differences in certain chemicals in the brain contribute to a chemical imbalance, which can result in depression. We have a chemical imbalance. Other things that are risk factors for depression, our environment. Let's think of 2020, let's think about that. What just happened? I'm having to walk around with a mask, or I'm having to stay at home. My life's been turned upside down, major life changes. So every single person has been through a major life change recently. But somebody who is continuously exposed to violence, so police officers, people who work in the jail, probation officers, CPS workers, APS workers, can get, I have them in my family, and they talk about, I felt myself where I just kind of put up this shield. I just don't even care anymore because I've seen so much. Somebody who is around a lot of neglect, abuse, or poverty can become very depressed. And typically that will come out in being angry, being irritable, being tired. Psychological factors with stress and trauma, and then personality. People who already have a low self-esteem, or who get easily overwhelmed, or who tend to be pessimistic, are more likely to develop depression. Physical illness. We know this. Whenever somebody gets diagnosed with a physical illness, even if it is something like last year, middle pandemic, I had a knee replacement. Now I'm down. having that where you can't do for yourself. You're having to depend on somebody else. But then think about those other diagnoses that we get. Whether it's us or whether it's our loved one. So physical illness can feed into depression. And then there are medications that one of the side effects are depression. So we've got to be careful with that as well. So the diagnosis of depression, we want to make sure that the symptoms have been there for at least 2 weeks. We want to start with a primary care physician, because as I said earlier, just like with dementia, we want to start with the primary care physician so that we can rule out everything else that it might possibly be. And they need to make sure and do a complete medical and family history, a diagnostic exam, an interview, a physical exam, lab tests to rule out other health conditions. Thyroid issues can also mimic and appear to create depression. Vitamin deficiencies can mimic depression. We can also see a psychiatrist who can order the same type test, but they specialize in mental health, and they can then perform therapy or they can recommend a therapist. Many times the psychiatrist will do the diagnosing, and if there's going to be medication involved, will diagnose the will write the prescription and then send you to a licensed professional counselor. Licensed professional counselors can do depression assessment instruments, and there's a couple of them on there. There's several that we learn how to do when we're in school, so we certainly see people who have depression all of the time, but somebody who's an LPC cannot write a prescription. And then there's psychologists who can provide in-depth psychological testing. So the good thing about depression, all depression can be treated. When you look up anything about depression, there are things that you can do for depression. 80 to 90% of depression can actually be cured. And then another 20%, even if it doesn't go completely away, they will see a reduction in symptoms. That right there is enough to go, we've got to ask for help. It is not a weakness. I'm so glad that more and more celebrities and sports stars are starting to come out and talk about it. And that makes it seem a little more normal. Well, if they suffer with it, then it must be okay if I have it also. The earlier treatment begins, the more effective it will be, and the quicker you can get to the other side of this. It doesn't mean it's going to go away forever. We may have another episode. We likely will have another episode, but then we've got tools. We're starting to build that toolbox. It is not a one-size-fits-all. So treatment is not a one-size-fits-all. And it usually takes time. And with medication, trial and error. Even with therapy, trial and error to find the best treatment that works for you. So speaking of medication, antidepressants are not habit forming, and they are not uppers. They are not happy pills. Those of you who remember when Prozac first came out back, I think it was the early 90s, and people were calling it a happy pill. That's not what it is. However, if you are somebody who is depressed though, and that particular type of medication works for you, then that might feel like a happy pill because your mood is starting to lift. But somebody else might take that and not have anything happen from it. And they might also have adverse reaction. Keeping in mind also with medication, it can take 2 to 4 weeks to work and sometimes up to 2 to 3 months to get a full effect. And most are recommended for at least 6 months. So many times people will go and they'll go ahead and get on an antidepressant. They'll start feeling a little bit better and they'll just stop taking it. Well, I'm feeling better. And we sure don't want to stop doing that. When we stop it abruptly, we can have a lot of withdrawal symptoms. And then the whole reason we were taking it in the first place was so that we could work through whatever issues, whatever it is that was going on. So many times what happens in those first couple of weeks is maybe the sadness is still there, but a lot of the other symptoms start to improve. Sleep, appetite, concentration. And that's why if you do go back to the doctor and you go, I'm just not sure this is working, it should ask you a lot of questions. Are you seeing an improvements in any of these areas? And especially these three: sleep, appetite, and concentration. Because if you're seeing some improvement there, then it's working. It's just taking a little bit of time. And then this is about counseling, cognitive behavior therapy. And this is typically focuses on reframing, focuses on problem solving or reframing in the present. And it helps us recognize our distorted or negative thinking. Because when we are depressed, just like all of those words that were coming up there, we can get to the point, I call it being down in the bottom of the well. I'm in the bottom of the well and can get to the point that there's no light. I don't even see light. How am I ever going to get out of this? So using that cognitive behavior therapy and helping you reframe the negative thinking. That also helps with goal setting, changing our thought patterns, and starting to respond to challenges in a more positive manner. And then there's interpersonal therapy that focuses on the client and the relationship with others, and really focuses on being able to recover from symptoms. And this is a shorter 12 to 16 weeks. And then there's a problem solving therapy. And there's many, many, many types of therapies. Again, we don't want to be here all day, so I'm just talking about these three. And this is designed to help manage negative, stressful events in life, focuses on a wide range of difficulties that come up in day-to-day life. Many people will actually start with cognitive behavior therapy, kind of get on their feet a little bit. Maybe they go and they get on an antidepressant, and then they may continue therapy and use problem-solving therapy to help them be able to maybe not have another major depressive episode. And we know there's definitely other things that we can do for depression. And the first thing that you're going to find if you do any research on depression is getting some type of exercise. Now, those of you who have been in a really bad place with depression know that is the last thing that you want to do. But we also know that if we can just get outside, take a walk, get on the bike, walk around the house, doing something to make ourselves move. Also setting realistic goals, not having that all or nothing thinking, because when one is depressed, we tend to do it will never, it will always. So trying to set some realistic goals and making sure that those goals are gradual and not immediate. I want to wake up tomorrow and everything be better. That's not realistic. So I want to wake up tomorrow and I'm going to set one realistic goal. Remaining social. That's been really difficult to do, but we figured out how to do it, because here we've got almost 200 people on this call, and no, we're not all together. But if we were all together, would we have had 200 people be on this? Probably not. So being able to remain social, reaching out to people, having someone to talk to. If you've got one person that can listen, that can make so much difference. Not one person to give you advice, but that one person that will just really listen and let you say the words out loud. In counseling, we use that term, if you can name it, you can tame it. If you can say it, you've got power over it and you can get on top of it. Making sure that we postpone any important decisions until we have a more objective view. You'll hear, like after somebody has someone who passes away, they have a major life, something happens that we're not supposed to make any major decisions. Getting education about depression, we all need to do that to help each other. Instead of looking at things as a large task, breaking them down into small tasks so that we can check it off and say, I did accomplish something. I was successful. I was able to do that. Setting those priorities goes right there with the goals. Working on our sleep, getting quality sleep, healthy diets, always going to come in. And then this is so important with depression, avoid self-medicating with alcohol and drugs. Healthcare workers, again, whenever you look at statistics right now of alcohol sales and prescription drugs being misused, healthcare workers, the numbers are up there, self-medicating. So how can I help someone who is depressed? Making sure that we are offering support, that we're offering understanding and patience and encouragement. Never, never ignore comments about suicide. If somebody says it, there's a reason that they're saying it. So what do? Making a connection. Doing our best to do you may not be able to fix it, but can you help them get to somebody who can help them? And when you are with them, that's why I chose these pictures of people just sitting there talking, going on a walk, having an outing, doing other activities together. When they do get in and they get a treatment plan, helping them adhere to that treatment plan. If they've been someone that's been turning to alcohol or who's been misusing medications, if we can help them stay on track, don't take them out for drinks whenever they're not supposed to be having drinks. Using other ways to distract them, keep them busy, help build them up and not tear them down. One thing is making sure they've got transportation to and from their appointments. Is there something I can do? Let me drop you off. Let me take you. Let me set up your computer. Let me help you figure out how to use Zoom. And then reminding them that it does take time and that it will lift. Share your personal stories. Sometimes that's one of the most important things we can do, is to just share our own story. Some resources where you can get more information and where a lot of these statistics came from is the National Institute of Mental Health, Behavioral Health Treatment Services locator. So you can go on there and you can find treatment. There are a lot of counselors doing things through Zoom right now. They've had to switch to this, and there's a place where you can find them. Your primary care physician's office, and then the National Suicide Prevention Lifeline. That is 24/7.
Hey, Holly.
Yes.
Can we have a couple of questions. I think it would be a good time to answer them.
Sure.
One question was, does everyone have some type or form of depression?
No, not everyone does, but it is very common. And when you go back and you look at all of those symptoms, typically what you'll see, is that you may have been calling it something else, and then you realize, I have had that. I have been through, and I just wasn't calling it depression. Now, in this past year, has everybody had some? It would be, I would think so, but we may not be calling it that. But we have had a lot of people are using the word anxiety. They're saying anxiety because we're getting kind of caught up in the what ifs. Anxiety tends to be more when we're worried about the future. Depression many times is when we're more focused on the past. So we've got a lot of depression and anxiety going on right now, but no, not everybody is going to have it.
And should a doctor be doing certain blood work on us?
Yeah, you want to have an entire panel. You want to make sure that you have a complete blood work, because there are so many things, like we said earlier, that can mimic. You can be having depression symptoms and it's your thyroid. You can be having symptoms of depression and it's some kind of a vitamin deficiency. So, and you're going to hear me say these exact same things when we get to dementia. So we always want to get complete blood work done.
Okay, so how hard or expensive is it to get diagnosed and treated if the patient does not have insurance?
Great question. And that's where we're going to want to reach out and we're going to want to get some resources. Donnie's going to have some more resources at the end of this as well, so that you'll have places to turn. There are a lot of counselors. There's a lot of places that will do some, where a percentage of their clients they see that they're doing pro bono. During this time, there's going to be agency. Another place that you can turn to is a college. Whenever I was at Dallas Baptist University, because we did not charge, you're seeing a student, but we're able to come through and see and at least get some help. So there are places out there. I would always start with primary care and get some resources there. But again, we're going to have some more resources at the end.
Right, and I think the last one, but you had all those lists of symptoms of depression. Are there a certain number of signs that determine depression? Like, do you need to have 2 of them? Can you just have 1? You need all of them? Right.
Well, I've got my handy DSM sitting right here with me on the table. So yes, there is, and I'm not going to be able to tell you right off the top of my head. Some of you might actually know better because Don't hang a shingle with mine, so I don't do this every day. But yes, there is a certain number of them that you do have to have, and it is 2 weeks. 2 weeks is the one that they look at. So you want to have the number of symptoms for over 2 weeks.
I think that's it for right now. Thank you.
Sure. Because a lot of times that situational depression that I was talking about within 2 weeks, that will lift, especially if it is something, you know, we may get in the bed for 4 days where we can't focus. I can't have anything, and then it just starts to lift. That's why it's got to have that 2 weeks to get the diagnosis. All right, so starting to kind of shift gears, and we'll kind of be going back and forth. This is really interesting to start seeing a tie and a link between, and this is fairly new, depression and dementia. When we have depression or anxiety that goes untreated for a very long period of time, it's damaging our brain. The chemicals are changing. It occurs within the hippocampus, and think about, what does the hippocampus hold? That is our primary memory center of the brain. That is another reason why it is so important when we're having symptoms of depression to get diagnosed. If the doctor recommends taking an antidepressant, it's okay to take an antidepressant. Typically, it's short term, just like we said, that all depression can be treated, and up to 90% of the time it's cured, but we've got to be willing to do it. If we have something going on that is changing our brain chemistry, and now we know that that brain chemistry changing can actually change the hippocampus, and we can do something about that. If it's temporarily getting into therapy, taking an antidepressant, making myself go for that walk. Another area that's damaged by depression is the conflict resolution center of the brain and the prefrontal cortex, which is associated with planning and executive function. The other thing that's there is reasonable and rational behavior. So you will see people who are really depressed, they're having issues with being reasonable and rational. With dementia, you will also see issues with being reasonable and rational. So they're starting to look at, what about people who have been chronically depressed their entire lives and it hasn't been treated, or they've gone on and off of medication, they've gone long periods of time where it wasn't treated, it's changing their brain. So we now have a link between lifelong chronic depression and dementia. So we're going to start again with dementia and kind of go through it in the same order, and then we'll bring them both back together. I had said earlier, dementia, just like depression, is an umbrella term. If somebody again were to say, my loved one has cancer, we immediately would say, what type of cancer? Same thing with dementia. My loved one has dementia, what kind, what type of dementia? It's a general term. There are a couple of different types of dementia that can present with no memory loss. Dementia just indicates that there's a problem with at least 2 brain functions. So there's got to be a problem with 2. Memory loss is just 1. Typically, we'll see it with memory loss, impaired judgment, impaired language. But there are over 35 common symptoms to dementia. So dementia, again, is not a specific disease, over 130 different types. It's a collection of symptoms, and they can be caused by several different disorders. So again, over 130 different types, we tend to see, and again, so number one question that Jamie and I get asked, what's the difference in Alzheimer's disease and dementia? Or we'll hear someone say this, my dad has Alzheimer's, but they don't have dementia. That statement is not correct. My dad has dementia, but he doesn't have Alzheimer's. That could be correct. So what that means is Alzheimer's disease, we've got that umbrella, 130 different types of dementia underneath that umbrella. Alzheimer's disease is the most common form or type of dementia. You can find statistics from 60 to 80% of all dementias, so 70s, kind of right there in the middle, are Alzheimer's disease. So my dad has Alzheimer's disease, which is the most common type of dementia. But what if they have frontotemporal dementia? Then they have dementia, but they don't have Alzheimer's disease. However, they could have both, because you can have a dual or a mixed diagnosis and have both. Vascular dementia is also very common, and we're going to talk about some of these a little more in depth. Parkinson's dementia, Lewy body. It is progressive. All dementias are progressive. They are going to get worse. All dementia is terminal. And so many times, we're the first time that families hear those words, progressive and terminal. It is not a normal part of aging. I just spoke with the Rotary Club earlier today and had people asking, but I thought it was normal to start to lose your memory. It is not normal to start to have memory loss. It is normal to slow down. It is normal to walk in the room and say, why did I come in here? It is normal to do, let me find that word, it's on the tip of my tongue. Hold on, it's right here. Where did I'm looking for my sunglasses, they're on my head. Those kind of things are normal. Actual memory loss is not, but there are things other than dementia that can cause memory loss. We just talked about one of them, depression. Dementia is also not contagious. And people will say that, I think I'm catching it. I think I've caught it. And it's usually someone who's taking care of somebody who has dementia who says that, because they're around it so much. Those of us who work in the field sometimes will say, I think I've caught it. I'm feeling like I've got, it's not contagious. So let me ask you this. And again, if you would please put it in the chat. So let me get where I can see it. I asked, when you heard the word depression, what was the first word you think of? When you hear the word dementia, what's the first thing you think of? Disoriented, inability, grief, memory loss, wondering, memory loss, Alzheimer's, memory loss, memory regret. Okay, so again, forgetting. So typically what people will say is memory loss, they can't remember, and they forgot. Those are all the same thing, because that's usually what we know, and we associate dementia with memory loss. So when we hear that word dementia, we automatically think memory loss. There are over 35 common signs and symptoms to dementia. So they're up on your screen right now. So many times after I'm talking with a family member, we get to looking back and they can start checking off from this list. Oh my gosh, they started that 5 years ago. I was seeing that 8 years ago. They started doing that 4 years ago, long before there was any memory loss. And they weren't realizing that those changes in the brain were already happening, because we now know that these changes in the brain can start taking place up to 20 years, possibly longer, before we finally get to the point that we go get that diagnosis. Because the other thing that happens with family members of those that have dementia is that we're great about denial, because it's got to be something else, doesn't it? It can't be dementia. It's got to be they're just getting older, or their hearing, or their eyesight, or they're depressed, because it can't be this. Because I know what that means. So when you start looking at this, and some of you mentioned some of these other ones, but for the most part, we were saying memory loss, they were forgetting, they don't remember. Now, here's the other thing with all of these signs and symptoms. I may have one family that sees throughout the course of the disease, let's say 12 years, they may see 8 of these, and another family may see 30. And another family may see 4. And another family may see 3 today. And before the end of the disease, they may see them all. We don't know. We never know, because everybody is such an individual. And this, the dementia signs and symptoms, you will tend to see the majority of these with all of the dementias. They may just come in a little bit different order. And so you'll see their memory loss, immediate memory loss, short-term, and then long-term. Long-term comes later. Some people actually keep their long-term memory throughout the course of the disease, or they'll keep it for a very, very long time. Starting to do repeated questions, or even any type of a repetition. Now, look at some of those other things that are coming up on there. You may be going, wait a minute, I saw some of these over there on the depression signs and symptoms, and you did. Look at some of those others that come up. Verbally aggressive, physically aggressive, comments about being a burden or a failure. So again, there's over 130 different types. I'm just briefly going to talk about 4 of them. Alzheimer's disease, we said, is the most common type of dementia. Literally, the brain is beginning to shrink. We've got atrophy with all of the different types of dementia, and the brain cells are dying. They have a continuous decline in thinking. They will plateau. They'll hit a plateau, and then they'll decline. They'll hit a plateau, and then they'll decline. There are things that can cause a decline. If they become really, really sick, if they get a bad UTI, if they have a bad fall, God forbid they have to have general anesthesia. General anesthesia, not twilight, not local, but general anesthesia. They will go to that next level of the disease. We now know why. We know that when they have general anesthesia, that plaque actually multiplies in the brain. So a person who has Alzheimer's disease, we now know they actually do have plaque that is growing on the brain, and they have tangles that are on the brain. They get trapped in that plaque, and it wraps around, it kills those brain cells. Because families will go, well, why is it that some days they can and some days they can't? Because early on, kind of moving in from the early to moderate, they're making that connection, and sometimes they don't, and sometimes they do, and eventually they won't, because those cells won't even be there anymore. When I first started working in this field years ago, it was the 6th leading cause of death in people over the age of 65. And then it was the 5th, and now it's the 4th. And if you look at all of the reasons that people over the age of 65 pass away, the top 10, Alzheimer's disease and other related dementias is the least funded of all of those. Second most common type of dementia is vascular dementia, and that's exactly what it sounds like. So anything that is bad for the heart is bad for the brain. So when we've got any type of an issue that is affecting our cardiovascular system, it's affecting our brain, whether we realize it at the time or not, whether we see it in our dad or our mom or our grandparents, our aunts or uncles or not, it's affecting their brain. Because it's caused by problems with the circulation of the blood inside the brain. Now, typically, it is caused from TIAs, those little small strokes, little pinpoint strokes. This is also the one that can have a sudden onset. All of the others, they're going to come on gradually, but vascular dementia can have a sudden onset because they can have a stroke and they've developed dementia. And they've developed some of those symptoms of dementia. So it can have a sudden onset. Now, let me back up just a minute. I've had people where their loved one had to go in and have general anesthesia. Let's say they broke a hip, they broke something, they have general anesthesia, and they'll say, Holly, he woke up from under the anesthesia with dementia. He didn't have it, and then he did. Then I pull out that list of symptoms and we start going over that, and they'll say, oh, well, yeah, he was doing that. He was, oh, I had no idea that that was part of dementia. And we realize he'd had it all along, but then he had the anesthesia, threw him over into that next stage. So he didn't just wake up with it from anesthesia, he had it. But with vascular dementia, they can have the stroke, they can have the event, and then there's the vascular dementia. So other causes of vascular dementia. This is uncontrolled high blood pressure, uncontrolled high cholesterol, diabetes, any type of heart issue. Smokers are at a very, very high risk for vascular dementia. Typically, you'll see their personalities and their emotions remain intact. It looks a lot different than other dementias do. Their judgment isn't usually affected until later in the disease. My favorite story to share about vascular dementia was I had a woman whose room was right outside of my office. She knew my name, she knew my daughter's name, she knew my story, she knew my car. She would watch me come in. She worked for me. She ran off all of my copies for me. She had vascular dementia. She loved watching all of the NCIS, CSI, all of the Criminal Minds, all of that kind of stuff. And every single morning when I came in, she would come over and she'd tell me all of the stuff that had happened to her in the night, and it is what had been on the TV before, but she believed it truly, truly had happened. But she could call me by name, and she knew my car, and she knew how to run the copy machine. So vascular dementia can present in a very different way, but her personality and her emotions were still intact for a very, very long time. The next type I want to talk about briefly is Lewy body dementia. So we can actually see these Lewy bodies that appear on the brain. The reason that it has the name is the person who figured this out, his last name was Lewy, and these are foreign bodies that are on the brain, so they're called Lewy bodies. Average onset is in the 60s. So many times people think of dementia and they go, oh, 80, 85. Now, when our day program was open, I had a gentleman who was 47 in the day program. There is a diagnosed case of early onset Alzheimer's in McKinney, Texas at 28. I know someone in Fort Worth who's 32. So it is not just an old person's disease. And especially as we look at Lewy body and frontotemporal, you're going to see the ages between 30 and 65. So with Lewy body, it looks like, and many times it presents as Parkinson's. And they may even get misdiagnosed as Parkinson's because it begins with problems with mobility and falls, their gait, a tremor, and hallucinations, and no memory loss. So you go in and you're this age and you say, I'm having issues with mobility and falls and a tremor, and I'm having hallucinations. And of course, the first thought is going to be Parkinson's. And what's really interesting is that you can have Parkinson's and Lewy body dementia. But Lewy body dementia presents as Parkinson's. One thing that makes Lewy body very, very difficult, because the only treatment we have, as we're going to get to, with all of the dementias, is we treat the symptoms. Even those memory meds that we're going to talk about, they're not treating the dementia, they're treating the symptoms of the dementia. With Lewy body, if you treat the symptoms, the mobility issues, it makes the hallucinations worse. And if you treat the hallucinations, it makes the mobility issues worse. So it's very difficult to treat. Frontotemporal dementia. Very first thing that we see are personality changes, and typically they are severe personality changes. Usually between the ages of 30 and 65, 50% of the time it is in the family, and there's 4 times more often it's in men. Judgment and social behaviors are affected first, especially being socially inappropriate. They'll develop that flat affect, apathy, so it presents as an emotional or a mental disorder. One of the very first people I came in contact with who ended up being diagnosed with FTD was sitting at a high school football game and started saying very inappropriate remarks to the cheerleaders out of nowhere. He'd not had anything else going on. That was the first thing that his wife noticed. He didn't have any memory loss. He was being very socially inappropriate at church. His judgment, spending money, giving money away. She was saying it was like he didn't care. She was getting ready to file for divorce. Went to her minister over it, who said, you've got to get him to the doctor. Thank goodness, doctor sent him to a neurologist. He had no memory loss. He had frontotemporal dementia. The memory loss came later. And we're going to talk about getting diagnosed, because I know that's going to be a question. So risk factors for dementia. Yes, age is definitely a risk factor. We do see it more with people who are older, but I don't want you to think, oh, I'm good, I'm 50. I'm all right, I'm 60. We see a lot. We've got a lot here of people who are younger than 65. Genetics and a family history, we've talked some about that, the smoking, the obesity, our lifestyle, alcohol use, already having a buildup of plaque. We've talked about the cholesterol. There is a high amino acid factor in Alzheimer's and vascular. And a lot of this information is really pretty new in the last few years, where we've started figuring out, wait a minute, what do all of these people have in common? Diabetes, somebody who's had kind of an antisocial life, not engaging in brain activities, and if they've been diagnosed with MCI or mild cognitive impairment, usually within about 3 years, 40% of the time, that will go ahead and become dementia. So how do we get diagnosed? Again, we want to start primary care physician. And that primary care physician, we need to, so at the first sign that we even might think it might be dementia, rather than kicking into denial mode, if we will start keeping a notebook of when did they do the behavior, what was it, what time of day was it, and when we go to the doctor with them, if they'll allow us to go with them. If they won't, there's a reason there's a patient portal, or that you can send notes over to a doctor ahead of time, and we can go, this is what I've been seeing. We all know if you try to think off the top of your head when you're in the doctor's office, you're going to forget everything. You're going to get too caught up. So I always encourage families, keep a notebook of anything that you're seeing that is not normal for them. So a thorough interview of the patient and that care partner, medical and family history, a medication review, because somebody who is not taking their medication correctly could mimic signs of dementia. Having that physical exam, a mental status exam, that MMSE can be done at a primary care physician's, complete lab work again, as much as they'll do, complete blood work. And sometimes that primary care physician will go ahead and order the MRI. What I've seen is most of the time they will go ahead and do a referral out to a neurologist or geriatrician. So they can also, same thing as a primary care, but they specialize in this field. We know primary care physicians, that's that umbrella where they know a little bit about everything, but that's not necessarily what they specialized in. They may go ahead and order some additional tests. They may do that lumbar puncture to test for proteins in the spinal fluid. What we used to have to do was just rule out, rule out, rule out, rule out, because the only time we could get a diagnosis was at autopsy. That's a little late. Well, now they can actually see it. So they may order that MRI, that CT, the PET scan, the EEGs from the neurologist. And then the neuropsychologist who can do the testing. And they will test orientation, memory, attention, verbal and written commands, and other cognitive abilities. Now, do you have to go to the neuropsych? No, you do not have to. Many times people will do it, especially if they're younger and there has been no family history and they're just wanting to know what is going on. We're trying to figure out what this could be. But no, you do not have to do that. So treatment and therapy for dementia. Like I said, there's no cure. We would love for there to be a cure. We would love to change the name of our center, but right now there's no cure. Medicines are used to treat the symptoms, and those, by treating the symptoms, we improve their mental functions, their mood, their behavior, their quality of life, their care partner's quality of life. Statistic is, and I don't know if I've got it on these slides, so I'm just going to put it in here, 68% of the time, that primary caregiver is going to die before the patient does. When the numbers for 2020 come out, I'm sure it's going to be higher than that because of what has happened with our at-home caregivers during this time. There's a number that 64% of the time, an adult child who's taking care of a parent and also taking care of their family, and they do it 4 years consecutively, 3 to 4 years consecutively, that they will die before the person with dementia. Heart attacks and strokes, stress. This is we talk about the family being the hidden patient. So another way, treating dementia, palliative care. Using it to improve a person's quality of life, focuses on the body, mind, and the spirit, and then making sure that the family has support early in the disease. Sometimes the person with dementia can undergo some counseling. They may need somebody to talk to them that's not a family member. And then those care partners, they need support throughout the course of the disease. Now, here are some of the most common medications. And if you work in this field, these are names that you hear over and over and over again. So what I've done is I've put on here the most common ones that we see and what they're used to treat. So you see there, Aricept is probably the one we hear the most, and that treats confusion. But again, you'll hear people say that's their memory med, that's treating their memory issues, that's treating confusion. And then we've got Namenda, again, that treats confusion. A lot of times with dementia, we will use an antipsychotic, and because those treat mood disorders. And what it might be used for in one person, it may be used for a whole nother reason in another person. And the worst thing to do is to pull up online and go, well, this says that we shouldn't. We've got dementia. We've got a terminal progressive disease. Let's focus on quality of life. It's also treated, it also is used for irritability, anxiety, depression, hallucinations, delusions, aggression, agitation, hostility, uncooperativeness, and agitation. And then you see antidepressants. And so there are, Remeron is an antidepressant that also is an appetite stimulant. And with dementia, we know that eventually they will start losing a lot of weight. Doesn't matter how much they're eating or what they're eating. Think about what controls that. The brain controls that. So when that part of the brain that tells the food to metabolize isn't there anymore, they're going to start to lose weight. This is some of those hard talks that I have with families. I don't understand why he's losing weight, he's eating, or I don't understand why he's not eating. Well, why do we eat? There's something in our brain that tells us to eat. So eventually they do stop eating. But with this, with Remeron, it'll stimulate the appetite, and sometimes for a while they may start to eat and you may see them put a little more weight back on. And then we can treat anxiety, restlessness. There's several different things here where we can treat symptoms. Now there's also some therapies that we use. People who have dementia can go in and out of physical therapy, occupational therapy, speech therapy, and music therapy, and it enhances their quality of life throughout the course of the disease. So physical therapy is probably the one that we see people go in and out of the most, because if you think about it, for a very long time, they still have muscle memory. Because think about when we learned that muscle memory, when we learned to walk, we learned to feed ourselves, we learned to put our own clothes on. 2, 3, we've had that memory for a very, very long time, and physical therapists can go and tap back into that muscle memory. So that reduces their fall risk. And having physical therapy, getting them to move, increases their circulation, which is good for cognition. Even if you've already got dementia, we want to do everything we can to improve our cognition. It helps with their muscle tone, their flexibility, their strength, their balance, their mobility. That then allows them to do more for themselves, keeping that independence and keeping that dignity intact. Occupational therapy. Again, they can also tap into that muscle memory. It helps retain existing functions for as long as possible. And this helps with activities of daily living. So this is where the OT can come in, and they may teach family members even that rather than, trying to brush their teeth for them, that usually doesn't go well. If you'll just get the toothpaste on there and get that hand up and get it going, or if you'll do it in front of them and they mirror you, you tap into that muscle memory, and let's let them do for themselves as long as possible. An occupational therapist can also advise someone about ways to adapt the home to make it safe for a person with dementia, and even help make arrangements to install grab bars, how to use a bath chair properly, and introduce a family to adaptive eating utensils and other modifications. And then there's speech therapy, and lots of folks won't think about speech therapy with dementia, but speech therapy with dementia is fantastic because stimulates that cognitive ability. It helps, they can use memory aids, helping with management with eating, drinking, and swallowing. So eventually, think about, there's a little flap right here in the throat. That's air, that's a liquid, that's food. What's telling that flap which way to go? The brain is. And eventually the brain quits telling it which way to go. Aspiration pneumonia, one of the top 3 reasons a person with dementia passes away. So swallowing becomes an issue. It's part of the disease. It's bringing those speech therapists in. And then music therapy is so phenomenal. We know that music is stored on the right side of the brain, and in people with dementia, the left side of the brain tends to deteriorate a lot faster than the right side, and music is stored on the right, and rhythm is stored on the right. So if we will use music, even with people, because I've had families say, oh, my dad's never liked music. Try it. Try it with dementia. Now, don't use your music, use their music. We don't want to use today's music. We don't want to use our music. We want to use their music and tap back into them. It helps so much. People who have already lost the ability to use those regular day-to-day banter words that are over here on the left, if you can tap in over here on the right, Christmas carols, happy birthday, and there they are again. They can sing the songs, but they can't say the words. Now, unfortunately, there's some other words that are stored on the right. Their sing-song, their sex talk, their racial slurs, their obscenities. Because once upon a time, we heard those words and our parents said, I better never hear you say that word again. So we didn't store it over here on the left with our day-to-day talk. We stored it on the right so that we could pull it out later. And those words stay, and they'll come out in a sing-song rhythm, all put together. People who we said, well, I didn't even know they knew those words. Yes, they did. But everything they do is a form of communication. They're trying to get a need met in the best way that they know how. So other interventions with dementia. That's why we exist. That's why we have an education department here at the West Center, because we believe education for care partners and for professionals to better understand the disease and the process of the disease. We're going to make our lives easier, the care partners' lives easier, and our residents and those living with dementia's lives better. Changing the environment, learning how to change the environment. We have to accommodate dementia. The person living with it can't. They would if they could. I have a sign in my office that says, the person with dementia is not giving you a hard time. The person with dementia is having a hard time. We have to accommodate the disease. They can't. Making sure that we monitor their personal comfort, learning to look at them head to toe, checking for pain first. They may be having a challenging behavior because they're in pain, and that part of the brain that's up here that's rational, that we would be able to say, I have a headache, I believe I need some Tylenol. They can't say that, but they've got a fist, or they can spit, or they can cuss, or they can kick because I don't feel well, and you're asking me to put on my coat. I'm still trying to make my need known to you, but I'm doing it with what I have left. We're not going to argue with somebody with dementia. You're not going to win, first of all, and it's just going to make it worse. Look for those reasons behind the behaviors, getting the adequate rest. We sure learn to be flexible when we're a care partner with somebody with dementia, having compassion, and then learning redirection. When we learn redirection and it starts to just come natural to you when you work in the field, you have a loved one with it. Top 4 things that we use for redirection. Food is number 1. The sweeter, the better. Their taste is going to change. They're going to lose a lot of their taste. Ice cream seems to be God's gift to dementia. Their music, you get their music together with something sweet, it's amazing. Animals and children, and if you don't have real animals or real children, pull up YouTube videos of funny baby animals is some of the best stuff you can watch. Babies laughing, children laughing, those are great to get somebody to look at. Somebody with dementia typically can do one thing at a time, so if you can distract them over to something else. Would you look at these little baby ducks here, and I've got my ice cream, and we can get their mind over to that. Many times we can get away from that behavior instead of trying to reason with them about why they don't need to be doing that. We accommodate it. So how do you help someone with dementia? You continue to build your skills. You learn as much as you can about the disease. You get in support groups and you talk to other people who are on the same journey that you're on. You focus on quality of life. Sure, learn to be flexible. We enter their world. They can't come to ours. We go to theirs. We have to learn to tell therapeutic stories sometimes. And then we've got to take care of ourselves. Practice self-care and compassion. So where can we go? Here locally, here's some places. So Alzheimer's Association, we're blessed. We have one right here in Fort Worth. That 800 number that's up there, somebody will answer that phone 24 hours a day. They can talk you through anything that's going on, even if it is 3 o'clock in the morning. They can walk you through and talk you through a crisis. They're a great place for information, and they've got a fantastic website. We also have Dementia Friendly Fort Worth that is right here that we are blessed to have as part of our community. There's the Area Agency on Aging, and there's our information as well. And finally, here's our information, and there's my email and my phone number. So you are welcome to contact me if you have got some questions or if you need more information. We are going to have some more resources for you here in just a minute. I'm going to go to Jamie real quick and ask Jamie, are there any other questions right now that I need to address before we switch over to Doni?
There are.
All right.
There's a handful. Trying to narrow them down. It's talking about depression. Can situational depression turn into major depression just because situations don't change?
Yes, it can. It sure can. If it's a situational depression and it doesn't change, it absolutely, it can become one of those, it can become a critical depression. It can become persistent depression. It sure can.
Does prefrontal issues cause depression, or does depression cause prefrontal damage?
There you go. Perfect. So that's what we're finding. We're actually finding that depression can cause that damage. This is all pretty new research that's coming out. So someone who has had lifelong depression, untreated depression, it can actually cause damage to the brain because those brain chemicals change and it changes the brain. So yes, depression can cause that type of dementia, yes.
And do you think we're going to see any post-COVID dementia that's progressive?
Well, we can sure tell you this. COVID made a huge difference in our residents, all residents, anybody who has residents, whether they have dementia or not. We saw a huge decline. There were a lot of people get diagnosed with failure to thrive. That's part of this program I'm doing with Leading Age Oklahoma, where we're talking about what happened to our residents and why did it happen. And I'm focusing really on loneliness and isolation and what that did. But does depression play into that? Absolutely it does.
Let's move on for the sake of time, if we could, and then if we have some time when Doni's finished, if we have some more time, we might jump in on a few more questions, if that's all right.
Sure.
Thank you so much, Holly. It was incredible. It was really, really good. Now I want to welcome Doni Green. Doni's with the Director of Aging at the North Central Texas Council of Governments, the Area Agency on Aging. And Doni, it's all yours.
Super. Good afternoon, everyone. I have just a few slides, and I'm going to move through these pretty quickly in the interest of time. But I'd like to focus on just a few selected resources for older folks who are dealing with depression, dementia, or both. But before I cover the specific programs and resources, I would like to share that these programs are funded by federal and state dollars, and the services are provided at no charge to those who qualify. And let me give you a little bit of information about our service area. We serve the 14 counties that surround, but don't include Dallas and Tarrant. With that said, most or all of these resources are available in both Tarrant and Dallas counties, just through different organizations. If we go to the next slide, again, just a few selected resources for older folks who are dealing with depression. Our agency administers a program called PEARLS, which provides phone counseling generally over the course of 4 to 6 months, and it helps participants develop plans for doing things they enjoy. And that was one of the treatments that, that Holly had discussed. Also keep in mind that if the person for whom you care receives Medicare benefits, Medicare does cover inpatient and outpatient mental health services. There's a wonderful program that is funded by the state in order to respond to COVID and the emotional stress that is accompanied dealing with a pandemic. The program is called Texans Recovering Together. Counselors can provide both short-term and ongoing counseling, and it is free and available to people of all ages, from children to older adults. We also work with a nonprofit organization in Plano called the Wellness Center for Older Adults, and under our contract with that agency, it provides caregiver counseling at no charge. Alrighty, so I would like to touch on just a few resources for people who are dealing with dementia. The Alzheimer's Association, Holly had already shared contact information for its helpline. Our agency also has care coordination programs, which provide temporary, generally 3 to 5 months of in-home services, supplies, financial help. I've provided our phone number. And then I also wanted to mention that we contract with the Alzheimer's Association, which does a number of workshops, has all kinds of support groups, as well as provides information and referral. Through our agency, we also have caregiver support coordination programs, which, like our care coordination programs, provide temporary in-home services and financial help. We have a respite benefit available through that caregiver support coordination program. And it's so important for caregivers to take a break, to avoid burnout. It's not particularly difficult to qualify for our respite program. That's the good thing. The bad thing is it's a very limited benefit. And for those folks who don't qualify for our Area Agency on Aging respite program, we have a similar benefit through our Aging and Disability Resource Center. So our goal when people call is to try to figure out a way to say yes. For family members who need help understanding their options in terms of paying for care, we have benefits counselors whose primary expertise is with Medicare, but they're also very knowledgeable in terms of Medicaid, Medicaid nursing home care, Medicare savings programs. We also administer the Long-Term Care Ombudsman program, and through that program, we can help folks who are thinking about placement choose the facilities that are best equipped to meet their needs. And then we also can assist residents of both assisted living facilities and nursing facilities in resolving concerns regarding quality of care or quality of life. I'd like to highlight a wonderful program that is offered through the Alzheimer's Association of North Central Texas. It's called the REACH program. And that program provides fairly intensive education and support over the course of several months. Historically, that program has been available in Tarrant and surrounding counties, but I'm really excited that we have received some additional funding, and we are now able to serve caregivers of people with dementia who live in Erath, Johnson, Navarro, Palo Pinto, Parker, Somerville, and Wise counties. And the association will consider serving people in other counties as well. They just need to coordinate if the county is actually in a different chapter service area. We also are happy to support the Caregiver Teleconnections program, which is a public service of the WellMed Charitable Trust. And that program provides monthly education and support, generally has 4, 5, 6 topics a month where folks can call in, get information, and also, just talk through issues, concerns with other participants. All righty.
Doni, there were a couple of questions real
Yes.
quick if we could. Someone asked if the the Wellness Center for Older Adults is only for Collin County. Do they serve other counties other than just Collin County?
So the Wellness Center for Older Adults is happy to serve anyone from the North Central Texas service area. So it will be happy to serve folks from Denton, Rockwall counties. Under our contract, unfortunately, it's not able to provide services to folks who are in Dallas or Tarrant counties, but again, it can serve any of the 14 North Central Texas counties.
You know, there was a different question that asked if you knew who served Dallas or Tarrant County with similar programs.
Yes, so the Pearls program is available through Community Council of Greater Dallas in Dallas County. In Tarrant County, it's available through a couple of organizations, United Way of Tarrant County, also the Women's Center. The care coordination programs that I mentioned, those are hosted by Community Council for Greater Dallas in Dallas County, United Way of Tarrant County in Tarrant. The Ombudsman program is through the Senior Source in Dallas through United Way in Tarrant. Benefits counseling is available through Community Council of Greater Dallas and United Way of Tarrant County. So for Dallas County residents, Community Council of Greater Dallas or 211 is the best place to get started. In Tarrant County, it would be United Way of Tarrant County.
Very good, very good. Very good. Thank you, Doni. Thank you very, very much. Appreciate it greatly. I didn't know if Hollie and Jamie wanted to address any more of the questions. That's the only ones I saw, Doni. There may be some more I missed. But if anybody, if you guys wanted to address any more questions.
We do have several. I just put up there, if I don't get to your question, please email me, because we have some that are very, very specific on the questions, and I know we are right. We've got like 3 minutes left. So I was gonna, Amy, is there one or two in particular that you want to pick out? And then if people can email me, I put mine on there.
Yes. So there was a question about treatments. Are there any type of treatments for early stage or early onset dementia? And kind of the same vein, are there any different types of symptoms that you would see for earlier onset?
Typically, if it's, if it's Alzheimer's, if it's Lewy body, if it's frontotemporal, whichever one it is, they will present in the same way, regardless of what age it is. And also the treatment, you're going to find the treatment will tend to be the same thing because it is so limited. They're going to treat the symptoms. Now, one thing that we will and we do see is that, you know, the earlier that we start seeing these and we start doing things like changing diet, making sure we're getting exercise, working on quality sleep, you know, doing all of those things that we do, healthy brain type things. Is it slowing down the progression? We don't know that it's slowing down the progression. Maybe it is. But is it changing quality of life by continuing to get that oxygenated blood up to the brain? Yes, we know that's happening. But the sooner the diagnosis, so that we can start doing some symptom treatment, and so that that family can start. And another reason, think about this, while a person is still able, if they have never talked about the plans they want for themselves, it is horrible to sit across from someone after a crisis and they're having to decide what to do. But I promised them I would never place them. And we never had a talk. We never filled out paperwork. I don't know their final wishes. I have no, early in the disease, they may still be able to have that talk. Instead of, you know, going through and everybody has that denial. But if we can just go ahead and start doing that symptom treatment.
I'm going to put up another slide real quick, just to let everyone know that that our group of presenters are going to be available next month. Can you see the slide? Are you able to see that?
Yes.
We're going to have the same presenters here next month, same date, same date, same time next month. We're going to talk about the heartbreak and costs of isolation and resources to help. I know Hollie touched on you know, the cost that it's or the toll it's taken on people in any kind of facilities. I think we've all seen it with people at home as well. And so so we'll be doing that next month. We have several other seminars going on, and one of them is going to be on Medicaid and Medicaid Made Easy. So please watch out for our emails. I am going to ask that the people that are joining us by phone, I know several of you have called in by phone. If you're not, either way, if you could email me and let me know your email address and what the phone number is you're using, that way we make sure that we get back to you the follow-up email that we're going to send once this is over, and you get the link for the CEUs if you're interested in doing that. I want to thank Hollie and Jamie and Doni. Thank you so very much. Thank you all for joining us. We did record this as long as it comes out okay, which it normally does. We'll be sending out a link in a few days with the recording and the slide download link again. Thank you again. Have a great day.